self-help book, your menopause book, make them read chapters as well, because they have no clue what's happening, because nobody does.
So just to piggyback on that, as the only male up on the stage. But I think it's really important, right? Not to belittle it, but you don't really understand what's going on with your body. We have no idea, right? And to your point, we just know that you're irritated with us with whatever we're doing. And so communicate these things to your partner. You'd be surprised. You may think, oh, my husband doesn't care. But they do.
Welcome to Baptist Health Talk, a podcast on all things healthcare, powered by Baptist Health South Florida, your trusted source for healthcare prevention and wellness.
Thank you so much, Valeska, and the entire Baptist Health team for believing in us, in all of us. And that includes men as well, doctors, experts, mental health experts, nutritionists, orthopedists, so many people. Because guess what? Perimenopause and menopause affects everything. Who forgot something this morning? Something that they had to do? Who forgot to even write down something that they had to remind themselves to do? And then they realize, oh, brain fog, once again, it attacks. Or you don't recognize your body once you see yourself in the mirror. And it's not about not loving yourself. It's just like not recognizing yourself. Or sometimes tears coming out of the blue, or sheer rage. And the people that you love the most, sometimes you cannot even stand. And everything starts changing. And then you realize our generation is not like other generations. Whether you're a millennial, elder millennial, Gen X, whatever it's called, we are not going to go in silence. We're going to do better. We are doing better. And Baptist Health is helping us do better by hosting this Menopause Unplugged, which has been until now Menopause Unscripted, because nobody was talking about it. And each script might look different, but you know what? Now you're going to have kind of like a roadmap, and you're going to know that you're not alone when you start coughing or sneezing, and sometimes maybe, oops, something happened down there. Or maybe, woo, you're feeling extra sexy, and sometimes you're not feeling sexy at all. And there's topics that nobody understands, and your mom never told you, and you don't understand what's going on. And it's like going through adolescence and puberty again. But for many of us who are moms, it's going through it when your daughter is also going through hormonal changes or empty nesting and so many other things. So I just want you to invite you to start thinking about all these questions that maybe you've been scared of asking, because we have, honestly, the menopause, the experts that are going to help us today. And this is only the beginning. We are only getting started. So I'm going to start first with Dr. Gila Senemar, who, if you haven't followed her on social media, you have to, because she has so much knowledge. She is a respected and renowned gynecologist, and she has been spending years helping women in all different stages of life. But now she's really helping us navigate perimenopause and menopause, because as we have already heard, perimenopause, 10 years more or less, yeah. So it's a long process. And some people might be navigating perimenopause and trying to conceive as well. So it's really interesting. So thank you, Dr. Gila Senemar, for being here. And next to her, please, a round of applause.
Thank you. Thanks for having me.
Oh, we are so happy that you said yes. And next to her is Dr. John Diaz. I've had the honor of working with him many times before. He's a leading oncologist at Baptist Health Miami Cancer Institute. He also has specialized in women's health, and he is so proactive about getting women to get the care that they need. But he also cares about women. So, Doctor, thank you so much for being here, and also for dispelling so many myths when it comes to women's health. We need you. We need more doctors like you. He's going to be talking about hormone replacement therapy, the risks. So you want to hear what he has to say. And then we have Dr. Rachel Rohaidy, a neuropsychologist at Baptist Health Miami Neuroscience Institute. She also has a very deep expertise in brain health, mood, all of this brain fog that I was alluding to, she knows, she understands, and we'll be addressing also topics like all these gray divorces and all our mood swings and why our mental health really can seem to take a beating during this stage of life. And we also have Dr. Rachel. Rachel, I already introduced. I was going to introduce Dr. Maria Kiriakou. Sorry, I got the accent wrong. Orthopedist at Baptist Health Orthopedic Care. She's also very passionate about bone density. Bone density, as we age, which is a privilege to be able to age, it starts becoming an issue. And it starts becoming an issue earlier than we think. So we really have to start thinking about not only our bones, but our muscle. And trust me, your joints. I'm a patient at Baptist Health Orthopedics, so I know a lot about joint health as well. So thank you so much, Dr. Kiriakou. And last but not least, Marta Graf, who is not only a fashion icon, but a philanthropist. And she has been building a business also, and she's so inspiring. I also follow her on social media for a while, but she's not only an influencer in the best sense of the word, but she really wants to help women feel empowered, stylish, and supported at every stage of life. And I honestly, it doesn't get any better than this. Look at around this room, all of you are inspiring in every single way. So I'm going to take a seat because, trust me, we're going to be talking for a while here. I have so many questions for all of you, and I'm sure you do too. So if you're like me and you tend to forget your questions, write them down in your notes app because I will be giving you the opportunity to ask every doubt that you have to this amazing panel of experts. So Marta, let's start with you.
Hello. Hello, can you hear me? Yes.
Yes. So you've been very vocal on social media and all media interviews about how changing the anti-aging language is so important, because it used to be anti-aging creams, anti-aging everything, right? From scalp oils and creams and lotions. And you're more about pro-aging, which is a very different focus. So do you think that there's a lot of fear around aging? And why do you think, as women, because I don't see it so much in men, we are so scared of aging?
Yes, absolutely. Hi, guys. It's a pleasure to be here. I can't even believe I'm sitting next to these experts here. I have a lot to learn today, and I'm sure we're going to leave knowing so much more about the subject. So the fear of aging started for me very early on. I was literally fearing the process. I wasn't ready, and I was told, I started modeling very early. I was 14. And, I modeled for maybe 20 years, but I always heard that I was getting too old at a certain stage of my life, where I was, on the peak of my career. And I started worrying, if I was feeling old on my 20s, how was I going to get ready, for my 30s, 40s, 50s, and all these amazing years that we have ahead. And a lot of the narrative, is like, oh, you're getting old. And I was told once, I always say this story because a guy looked at me and said, oh, you had passed your prime. And English wasn't my first language. Today, my English is better. But at the time, I had to Google that. And I said, what does it mean when a woman's past her prime? And I understood he was telling me that I was old and I was in my early 30s. And that really ignited me and made me even call my company that is, a longevity women's-based supplement company, that Happy Aging, because it inspired me to change the narrative. It was enough of making women feel scared of aging, feel scared of this process that is so natural. And I wanted to change the anti-aging narrative to feel more comfortable with all the changes that we are all going to go through. And it's funny because I didn't have that conversation ever before. So I spoke to my mother the other day and I said, Mom, how was your menopause? I was preparing for this. How was your menopause? What did you feel? It's like, oh, I didn't go through that. And I'm like, what do you mean, Mom? Of course you did. Didn't you feel so-and-so? Didn't you wake up at night? And she's like, yeah, of course. I had insomnia and then I started taking pills to sleep. And now that I see, and a lot of our moms never spoke to us about this. She was battling a cancer, colon rectum cancer at the time. She was going through menopause, and she was taking care of everything like all women do, and don't want to show, the vulnerability of going through that. So what I want with this narrative is, with this conversation, is like everyone else here, is just to get empower other women. I'm entering my perimenopause stage. I want to make it look normal to speak about it. So many women don't find it sexy, to speak about this on social media. Now we're seeing a lot of people like Hailey Berry and other women that are just, making this a normal conversation. So I do want for us to feel empowered and to live or start now, so we can be on our 50s, 60s, 70s, 80s, feeling our best, and this start with small habits today and education.
I love that. And also what you mentioned is we might feel different, but that doesn't mean that we're worse than what we used to be. And I think that is one of the many misconceptions. And Dr. Gila, you deal with misconceptions about menopause and perimenopause all day. You even make fun of it because there's so many ridiculous things going on and so much misinformation. What would you say is like one of the biggest misconceptions about menopause and perimenopause?
So, we have to make light of this topic because it's so prevalent. I hear it. Like you said, I see about 30, 40 patients a day, every week. And they come to me and they've been dismissed by their healthcare providers. People that have been taking care of them for years, delivered their babies, have seen them through all different stages of life. And now they've been told, you're still having your period. You don't have hot flashes. You're 41 years old. You're not there. That's not what it is. Maybe it's, you should see a therapist. Maybe you should start on some anxiety medications. And so we are, we as a community, medical community, it's easier for us to just dish out anxiolytics and sleeping pills and antidepressants than to actually get to the root cause of what's going on with women, which if you take a step back and look at women as an whole individual, not just the reproductive parts, as what we call in our thing, boobs and tubes. Look at them as a whole person. What is going on, right? There's more to it. Their hormones run everything in our bodies, just like your thyroid does, just like your adrenal glands. Your ovaries are the same. We have hormones running the show. And in perimenopause, it starts to decline. So, and it's the chaotic zone where it can last between 5 to 10 years. And I've had women, unfortunately, come to me who have lost a good 5 or 6 years of their lives to this. And they're at their end point and they're like, I'm just going to try anything and everything. And maybe this one doctor will help me. So that can't happen anymore. Like you said, this is not that generation that's going to go away, suffer in silence, and be quiet about it. We're loud, we're proud, and we're going to thrive through this whole stage.
And it's all about thriving and also being our own advocates. And that means also going to experts that really know what they're talking about, because we were discussing a little bit before we started this conversation here that some doctors just dabble in one thing or another, and other doctors really go in deep, and those are the doctors that you need to seek out. And one of those doctors that I look up to is Dr. Diaz. And we're going to talk about hormones, doctor, because there was a very infamous, I want to call, study, the famous Women's Health Initiative study in the early 2000s, which I believe has done a great deal of harm to women's health, because it made many women believe that HRT, like hormone replacement therapy, is dangerous, right, across the board. And so for over 20 years, women were told that you just have to suffer through all these symptoms and bone loss and just deal with it, right? Can you explain what that study actually found and where it was maybe misunderstood, and why many of us, when I hear about that study, I don't like it?
Yeah. So the WHI study was a very well-intentioned study, and it's still one of the largest studies that we've done to look at the role of hormone replacement therapy in women. And it was actually 4 studies in one. And it was looking at treating women who were the ages of 50 to 70 with hormones to prevent chronic disease. So it really wasn't aimed to look at a lot of the things that we try to manage every day, such as menopausal symptoms, hot flashes, vasomotor things. The aim of the study was to see if we used hormones, could we prevent diseases like cardiac diseases, like preventing certain cancers. And it was really 4 stories in one. So one was an estrogen and progesterone arm. The women received oral medications that we don't really use today. The other things that they looked at was calcium and vitamin D supplementation and also diet. Could these things impact? And again, it was a well-intentioned study. The problem was we didn't really look at the right population of women. And although the study was open to women between 50 and 70, the majority of the women, or the average age women in this trial, was 63 years. So to Gila's point, that's 13 years after menopause. And so we weren't really looking at the right group of women. And so what the study showed was that those women who were taking at that time hormone replacement therapy, which again was an oral estrogen and oral progesterone in doses that we don't really use nowadays, it found that unfortunately this actually was hurting women, right? So that study demonstrated there was an increased risk of stroke, cardiovascular disease. There was an increased risk of breast cancer, maybe even an increased risk of ovarian cancer. It did have some positives. It did lower the risk of colon cancer. But the challenge with that study was, again, we weren't looking at the right population. We're not using the doses that we would potentially use today. And the study was stopped early, which was good because we saw women were being hurt by this. But unfortunately, because it got stopped early, the news grabbed a hold of it and said, this study has shown that it increases your relative risk of breast cancer by 26%. That's a big number. That's a scary number, right? But when you looked at the actual absolute risk, it was 8 more women per 100,000. So yes, it did increase it. But again, we were looking at maybe not the right cohort of women. And that stopped everything, including that study. So that study was stopped early. So we didn't get to see the long-term potential benefits of this combination. It also had ramifications for other studies. So in our field of G1 oncology, we were looking at women with uterine cancer, which is the most common GYN cancer. Could we use estrogen to help these women with their menopausal symptoms? And that study was closed early because of these findings. And so it really stunted any research at all at looking at hormone replacement therapy. And so the study showed what it did show, but again, it probably wasn't the right population. So we were trying to prevent disease, but we were looking at women who were already 13 years into menopause. So it's hard to prevent something when you've been in this chronic disease for so long, right? And what we're talking about today probably is, what about a much younger group of women? Women that are just starting to enter that perimenopause or that menopause, or within a couple of years of menopause, and they'll see Gila and say, you know, I just don't feel right. And so that's a different group of women I think we're going to talk about today. And so that study, while well-intentioned, and oftentimes when we do things in medicine, we're well-intentioned, it really didn't answer the question that we're asking today. And it really wasn't looking at the right population of women. So, you know, it showed what it showed. And we've learned from that, but it really stunted research in this area, which is so important.
So important. And also, I feel that there's been lacking some research, Dr. Rohaidy, on mental health in women who are entering perimenopause and menopause. Like I was mentioning in the beginning, the brain fog, the confusion, menodivorce, that rage sometimes, the sadness, the grief, like so many conflicting emotions all at once, the lack of patience. And many women are getting diagnosed with ADHD, it seems, in their 50s after maybe masking or managing what they had all these years. But it seems that once your hormones start shifting, like the real you, I guess, in many ways starts like sifting through. What is going on with mental health in peri and menopause?
So this is quite a complicated topic, right? So I think it's definitely multifactorial, especially with the menodivorce, right? The phenomenon of gray divorce. So we're looking at not only physiological, biological changes, right? Hormonal changes, where that's affecting quality of sleep, it's affecting our mood, affecting libido. So right there, just those three little things, right, are affecting how we are and communicate in our relationship, right? Because we're not living alone, we're living with a partner. And a lot of times those partners don't understand what's happening to our bodies, nor do we, because we're not getting the help that we need from our physicians. I remember when I first started having some issues, I went to my gynecologist and he said, "Congratulations, you have a uterus." And that was the end of the conversation. So, and I say that because it still pisses me off until today. So, it happens to us as well, being in the field of medicine, and our own colleagues, unfortunately, don't understand how to have these preliminary conversations with us. And so you have a partner who is now trying to navigate these mood swings, right? So you have these hormonal shifts. You have also these kind of psychological issues that are happening besides the biological. So you have anger, which leads into anxiety, depression, which leads into this cognitive fog because you've had this lack of sleep because of these hormonal shifts. So you're more irritable. You're not concentrating as well at work. Maybe there's issues at work. You're forgetting things. You're all sorts of yumminess happening there. And then you've got issues at kind of the sociological level with kids going off to college and taking care of aging parents and maybe some financial issues happening. So we've got a nice big snowball of things that can directly affect our relationship. So it's not just one thing. And I love how it's menopause caused my divorce. And it's not menopause that causes anything. It's the snowball effect of all these little things and the lack of education that's out there, the lack of help. And what I love about, and it's going to sound kind of weird, what I love about post-COVID is that we have these platforms that we never had before. Maybe we wouldn't have had them. I don't know. But because of COVID, we have this explosion of Instagram and TikTok and I don't know, these other things that are out there. I'm not very savvy, but where everyone came together as a community, everyone's teaching somebody else, and we have a voice. And all of a sudden we're learning about menopause and everyone's saying, it's okay. Look, I'm going through it also. And there's communities and there's support. And so this is, and I think we're going to hopefully we'll see less of this divorce issue at some point. But I think for right now, you get to a point where enough is enough and relationships split. But also, men undergo their own andropause, right? Testosterone decreases, so they're going through their own midlife issue. We can't communicate anymore because instead of me actually communicating and saying, well, I'm irritable because I haven't slept, it's not necessarily because of you. Right? It's you're pissing me off. Don't talk to me anymore. You're chewing too loud. Don't, you smell. Get away from me. Don't touch me. I hear it as a psychiatrist. I hear it all in my clinic. So, it's these, it's like I've become a therapist in my clinic. Sometimes because couples come in and I have to, send them individual therapy and family therapy. And it's not just about medication, but it's a breakdown of communication.
And in all fairness, if we as women are learning to navigate this, right? We're learning as we are going through it. Our partners also don't know anything, right?
No.
They're learning with us.
Yes, absolutely.
So it's a complicated process.
So when you buy your self-help book, your menopause book, make them read chapters as well because they have no clue what's happening because nobody does.
So just to piggyback on that, as the only male up on the stage. But I think it's really important, right? Not to belittle it, but you don't really understand what's going on with your body. We have no idea, right? And to your point, we just know that you're irritated with us with whatever we're doing. And so communicate these things to your partner. You'd be surprised. You may think, oh, my husband doesn't care. But they do. They do care about you. They do care about their relationship. And they want to understand, why is she always mad at me? Why doesn't she want to be intimate anymore? Like, what's going on? And so communicate those things to them. And I think you'd be surprised about how understanding they're willing to be.
Right.
And once we understand, okay, it's not that you don't find me attractive anymore. It's
Right.
that you have things going on, or it hurts when we're trying to be intimate. Then you can have someone, a partner,
Exactly.
that will help you navigate these things. They want help. They just have no idea. And although you would think, well, no one wants to hear the word menopause if they're a man, but it's important to understand what's going on the other side of the bed there. What are they going through? And you'll see that if you help them understand it, I think you'll find a partner to navigate this, and you can do it together, which will be a lot easier than trying to both go at it separately.
Yep.
I feel that that's such an important conversation to have. And now we're going to talk about bone health, which is a big topic because, Dr. Kiriakou, we're listening to all these people saying that, okay, cardio is not so important once you go into perimenopause. It's all about lifting and lifting heavy and becoming stronger. How important is it to lift weights? How does it affect our bone loss? Like, how does this come into play with protecting our health?
Absolutely. And so thank you very much for having me. It's very exciting to be here. So in terms of when we're thinking about our bone health, it like everyone else has been saying, you know, nothing is simple. Everything is a little more complex than we realize. When it comes to exercising and making sure that we continue to maintain our bone health, it actually starts at a much younger age. There's a lot of studies that are out there that says, well, once you start hitting perimenopause, menopause, and you have your estrogen hormone that's going down, you have a significant reduction of your bone mineral density. It actually happens a little earlier than that. There are studies out there that are showing near your mid-30s that we're already starting to have this small decrease in the density of our bones. Now, when it comes to maintaining a healthy lifestyle, good diet, good exercising, cardiovascular, of course, is extremely important. A good cardiovascular exercise makes sure that the heart is healthy, the lungs are healthy, you're getting the oxygen that is required to maintain your muscles and being healthy, and everything is connected, including your muscles to your bones. When you're running, when you're walking, any high impact activity, that pounding stimulates cells in the bones to trigger them, build more bone. But when you're doing your cardiovascular activity, you're using your muscles, that's also stimulating the bones to stay healthy as well. You have your muscle that is then the tendon that connects to the bone. And so that contraction of your muscle, that tension coming from the tendon to the bone, that's something that's also very important to maintaining bone health. Now, the reason as we get older that weightlifting becomes more important is because there's a lot of things. Again, it's not just as simple as saying this to this to this. There's a lot of different outlets that are affecting the health of our bones, whether it's hormonal, whether it's something medical that you're going through, but it's also the exercise, the activities. After a certain point, when we hit menopause, perimenopause, and menopause, you have that significant decrease in the density of your bone because, yes, a huge component is the estrogen hormone. So how do we maintain the health of our bones? There's other factors, which is, yes, the weightlifting, but you definitely don't want to ignore the cardiovascular, because if you completely ignore cardiovascular, then you won't be able to optimize your weightlifting part. You'll get fatigue a lot sooner, or you might not have proper balance and strength to make sure you don't injure yourself. So you do want to continue the cardiovascular exercise. You just want to implement more the strength training exercise, because it's not something that we do as we get older. We get a little tired. We have other things in life that keeps us busy. And so we kind of put to the wayside the weightlifting component. Another thing that happens to us, unfortunately, somewhere between the ages of mid-40s to mid-50s and even 60s, is something to the muscles called sarcopenia, where they start to atrophy. They shrink a lot quicker, and it takes a lot longer for them to re-strengthen. So if it's not typical activities that you've done at an earlier stage in life, trying to do it at a later stage in life can be a little bit difficult, challenging, but also can increase risk of injuries. So that's why it's super important that, yes, cardiovascular is extremely important, but you want to maintain some sort of strength training regimen at an earlier stage in life. So once we get to the point that I'm starting to hit menopause, this is really when that estrogen goes down, the bone mineral density will start to go down too. You have something extra in your playbook that's going to maintain the strength of your bones, and that is the exercise part, cardiovascular as well as weightlifting.
And Doctor, just a quick follow-up. Is it too late to start?
It's never too late to start. It's never too late. Now, of course, if we can start sooner, you implement that habit, and it's much easier to maintain it throughout the rest of your life. Now, if we start a little bit later in life, that's okay too. You can start small, bring it up in increments. Always, of course, talk to your physician to make sure that any kind of activities that you want to start is safe for you, whether it's a medical component that you need to make sure won't increase your risk of an injury, or just some kind of mechanical component. If you've had arthritis in the past, if you've had a previous injury in the past, that doesn't allow you to optimize your exercise regimen. But no, it's never too late.
Which is great to know. So we can all start today if we haven't started yet. And Marta, you were talking a little about all these experiences as a model. You've also been really outspoken at how much self-damage we can actually do to ourselves when we're growing up, when we're still figuring out who we are. And for those of us who are moms, especially those of us who have daughters, what should we be doing in the way that we talk to ourselves that will also improve things for our own children?
Yeah, I am very open about my struggles, growing up, because I left my house very early on and I didn't have anybody, telling me, how to be healthy and what to eat. I guess I went to Europe and I just I made this diet that I lived in ice cream and cakes because I was an early, young model, and I could just take care of, my nutrition, and I didn't have any guidance. But mostly I was very insecure. I was mentally, I saw the changes coming in my body, but I wasn't prepared. I didn't have a conversation with my mom when I said I got my period. She's like, here's the pads, good luck. And we didn't have a conversation about that either. So I struggled with eating disorder for 12 years. I learned how to harm myself very early on. And I think children are masters in hiding. I was so good at hiding. I hid it from my parents. I hid it from my friends. Then later on, my boyfriends. And I guess that having those difficult conversations, early on about your body's going to change. Suddenly there will be like a weight gain that it really came out of the sudden to me. I put on 10 kilos like that. And that's when I started purging. But I guess with my daughter and with sometimes other moms come and say like, oh, Marta went through this. Why don't you talk about that? But having these hard conversations, this is what's going to happen with you. And I always think that for children, the most important thing to work early on is their self-confidence. Being, a child that I lacked it. And just now on my 40s, I'm starting to realize how important it is if I would have that self-confidence, if I, talk to my parents about these things and really build that confidence in myself and know what's going to happen, with all these changes. And these conversations, it's the most important. Just the same, like we're talking about speaking to our husbands about perimenopause and menopause. Also, maybe talking about your changes, or your hormonal changes to your children. So it goes both ways. You're going to be supporting them, and by sharing and also educating them early on about your hormonal changes and what's going on with your body, I think it will prepare them, because I didn't have social media when I had all these issues. And I imagine now how hard it must be, the comparing game and looking at all this perfection out there. And, I guess I feel for them. I really feel for the children. So difficult conversations with children, with husbands, and everybody around us.
Employers, everybody. But I do think that the more that we talk about things, the more we normalize it, and we realize that the only constant is change, and change is okay. Instead of fighting it, let's embrace it and make the most out of every single stage that starts changing us, both internally and externally. And in that sense, Dr. Gila, we've been talking a little bit about hormone replacement therapy. Many people call it hormone support therapy. What are the guidelines? Is it something that once we start, we have to do it forever? Honestly, so many of us are lost around this topic.
So there's a lot of different terminology, but it's all pretty much the same. HRT, menopausal hormone therapy, MHT, hormone optimization therapy, one and all the same. Basically, what we're looking at is there a time to start? Absolutely. When the symptoms are bad enough where they're affecting your quality of life. That's the bottom line. You do not need to be in menopause. You do not need to be the average age, which is 51, where you haven't had a period for 1 full year. That's the definition of menopause. Any day after that, you're considered postmenopause. And any time before that, you're in perimenopause. So anywhere along that journey is when you start hormone therapy, especially if your symptoms are bad enough where they are affecting you in every way, affecting your relationship with your partners, affecting your relationship with your kids, at work. It does affect everything, ladies. It's not a one-sided equation. We all know that far too well. We see it far too well. We see it across the board everywhere. And so, yes, the partners need to be brought in. Everything can be started. And what are hormones? They're basically what your body used to make, but it's not making it anymore. We're just putting it back in. If your thyroid isn't functioning and you're hypothyroid, what do? We give you thyroid medication. And do we ask, do I need to be on this for the rest of my life? We pretty much know the answer is going to be a yes. So with hormone therapy, look at it the same way. We're going to start you back on everything. Are you going to be on it for the rest of your life? We'll see. The answer is there's a timing hypothesis. The first 10 years after menopause is when you're going to have the most benefit from those hormones with the least amount of risk. Okay, so that is the typical answer you're going to hear after, let's say you're 61 now. So you've been on it for 10 years. Do I take you off at that point? No, we have a conversation. We talk about it. How are you feeling? Are there any medical changes? Anything new that we need to know about? And if the answer is no, then we continue for another year. So the goal is to optimize you. And why do we say those 10 years right after is because that's when you're going to see the most bone loss. That's when you're going to have heart disease start to peak up, and then the cognition component. So we really want to get ahead of it. And then I'm going to give a little more in that perimenopause stage. Let's say you're 45. Does that mean you only get it 10 years? No, actually, you get it from 45 until you hit 50, 51, then you get another 10. So basically, you may get a good 14, 15 years of hormones, okay? And then there's a whole other side to that too, premature ovarian failure, so women in their 30s. And to me, they're the most critical that need to be addressed because they're losing their hormones, whether it's surgically for some kind of GYN cancer or some kind of autoimmune issue, and they will lose their hormones rapidly at a younger age. Hence, their body is going to be affected a lot more drastically. So they will need hormones sooner rather than later.
So we really have to discuss this with our doctor because each path is going to be individual depending on your history, on whether your cholesterol starts shooting up, then you have health concerns. There are so many things to factor in. And one of them, Dr. Diaz, is the whole notion that hormones might not be the solution for all women, right? And that some women are very concerned and they're justified in being concerned. When is HRT not recommended at all for women?
Yeah, so to Gila's point, we have to understand what are the goal that we're looking for. Is it vaginal dryness? Is it issues with mood? And then we have to see what are the options in both hormones and there are non-hormonal options that are very effective too. And everything we do has risk and rewards. As far as absolute contraindications, anyone obviously who has any kind of cancer that would potentially be stimulated by estrogen. So if you have a history of an estrogen receptor positive breast cancer, then, something we can't use. We used to say endometrial cancer, most of which tend to be estrogen, that was an absolute no. I talked earlier about that study that was looking at that and stopped early. So that one becomes a discussion of risk and benefits and what are we trying to do? So if it's vaginal dryness, a little topical estrogen cream has very little systemic uptake. And so I think that's very reasonable. But those are the ones that we would say absolute. So if we know that you have a cancer diagnosis that is sensitive to whatever hormone replacement we're talking about, be it estrogen, progesterone, testosterone, then those would be that. But most women don't fall into that category. And then it becomes a discussion of risk rewards. So if you have a particular cancer in your family, does doing this increase your risk? It might. But does it improve your quality of life? Or what is the symptom we're trying to do? Or if you're suffering from osteopenia. So we have to strike that balance. But the important thing of the take home is start those conversations early. Don't wait until it's unbearable. Don't wait until you've been suffering for 5 years. And if you're not getting the answers that you like, then find another doctor, right? And ask your friends, who did you see? Did they really listen? Did they address your concerns? Or did they just say, congratulations, you have a uterus, and move on? And so I think it's really important. But there are some absolute contraindications, but mostly are those women who have either a known cancer risk or a significant cardiac risk or stroke risk, things of that nature. But most women could probably benefit from hormone replacement therapy. And again, the discussion to have is, what is the goal? What symptom are we trying to improve?
And is there a different risk associated with patches, whether you use a patch or whether you use gel or roll-on?
Yeah, it's a great question. So again, the WHI study was oral progesterone and oral estrogen in doses that we don't really use today. Most of the time what we're using today is the transdermal patch, which delivers a much lower dose, right? Most of the progesterones we're using today are micronized progesterone. So again, very different the way that's being delivered. And what are we trying to target? So there hasn't been any head-to-head of oral versus transdermal directly in clinical trials, but most of us have moved away from oral treatments. Plus, it's just easier to put a patch on, remember to take a pill every day. And the doses are much lower. So we have to titrate. What are we trying to do? Right? What are the symptoms that we're trying to improve? And then respond to that. And then I'll just finish with one last anecdote. I had a federal judge, obviously a very intelligent woman, who was diagnosed with uterine cancer. She was on estrogen replacement therapy. We stopped it once the diagnosis was made. She was treated. She was doing well. She came to see me about 6 months after, and she's like, "John, I'm miserable." I said, "Okay." And so we talked about it. We talked about what are the risks, what are the benefits, and ultimately we decided together that she would accept whatever minimal risk might be associated with, but to restart some low dose of estrogen therapy to help her with the symptoms that she has. Because we had cured her from cancer, and now she was miserable, right? And so it has to be a balance. We have to have quality of life in what we're doing.
So important to know and to have that discussion. And Dr. Rohaidy, I mentioned in the beginning, we've also talked about it, how in this stage we start forgetting things. And there's a cognitive component that is very serious. It affects on so many levels, yes, because it affects us not only in our family, it affects with our friendships, with our work.
Absolutely.
Is there anything that we can do to fight this cognitive change, this forgetfulness? Aside from writing everything down and then forgetting to look at what you wrote down.
So a little bit on my story. I had babies via IVF. I had them late in my 40s, and I have twins, and I have an 8-year-old. So I have a 6-year-old and I have an 8-year-old. I'm 50 years old, and I don't have a brain anymore. It was completely sucked out of me, and that's way before any menopause thing started. And definitely mommy brain is a real thing. And I definitely feel I never recovered from mommy brain. I don't know if it's because of the exogenous stuff that I was putting in my body or because of the actual birth. I have no idea. On top of the added stress, I got diagnosed with RA. So now I'm on biologics because of the RA. So there goes a little bit more of my brain.
Rheumatoid arthritis for those of us.
Sorry, yes, rheumatoid arthritis, right. And so then now menopause. And I have my patch on, and I'm very happy. I remembered to put it on this morning. So it adds up. And there are some really small studies that are coming up. Mommy brain is a real phenomenon. Do women actually recover from mommy brain? I have no idea. I can honestly tell you. I don't know. But there is a true, real phenomenon that happens when women give birth that also cannot be ignored, which also we need some more kind of light put on, because I have a lot of women, younger women, who come to my office and say, you know, I'm 6 months, a year postpartum, and I don't know what the hell I'm doing in my day. Right? So when we reach this stage of perimenopause and menopause, and it gets worse. And I have diagnosed so many women with ADHD also on top of it, not just because of menopause. I'm not going to say it's menopause, but because women tend to be missed in school. And that's a completely different topic, right? So we have inattentive and hyperactive ADHD, and you've got to really have a good conversation with your psychiatrist and really good clinical diagnosis and testing, and really tease out what's going on and what's happened through the years to see, you know, what is it that's going on? Is it really inattentiveness? Is that really what's happening? Or is there some other things that were happening before, right? Because I also have the admix of some domestic violence or some PTSD that could be admixed in there as well. But women tend to be, or girls in school tend to be missed because we don't misbehave. We're quiet, but we're like this in class, right? We don't misbehave, but...
Or spaced out.
Right. So for a while there, my 8-year-old does have ADHD, inattentive type. And I thought she was having absence seizures. I swore up and down she's having seizures. So I ran her to the pediatrician. It's not seizures. She has ADHD. Right? So because I also have ADHD, which was never diagnosed because I came from Cuban parents who were like, you're just not trying hard enough because you're not paying attention. So I think that when we all really start paying attention to our symptoms and talking about things and not blaming our children for things that are really out of their control, and start seeing what's going on and seeing what's happening, and open communication in the family, I think starting that is really going to help that family dynamic as we go. Sometimes some of us try to go back and try to talk to our moms, because I've tried that also, trying to talk to my mom about things, and that doesn't really help. I mean, you know, there's sender ways, you know, that's it. But I think it starts with us and talking to our children now and changing that narrative so that we can move, so that they can move forward when they have kids.
And is there like any practical tip to deal with brain fog? Like, is there a supplement that we can take?
So I always I'm definitely I'm not a pill pusher with my patients, but when there is depression or anxiety, I do believe in medication because I've seen it help. You've got to find the right medication for you, but also healthy eating, staying away from toxins, sleep hygiene, taking proper vitamins, not vitamins, but, you know, proper vitamins, multivitamin, omega-3, something that's very brain healthy, exercise, making sure you're following up with all of your doctors, going to your yearly doctor exams. But staying away from toxins is number one.
So important.
Yeah.
I'm just so glad we're talking about all of this. And Dr. Kiriakou, we haven't forgotten about you, because there's also a very important test that we have to do, right? And it's about our bone density. And we hear about mammograms, we hear about other kinds of tests, but people don't really talk that much about bone density. When should we start with our bone screenings?
So when it comes to bone screening, 65 years of age is when we do it, but there has been some changes to it. And it depends, again, that's why it's so important to have your yearly exam with your physician, because it depends on your family history. It depends on your own medical history. So if there is a history of osteoporosis at a young age in your family, your brother, your sister, your mother, if there's been some kind of fracture from sitting to standing, and you don't know why you've broken your ankle from such a small, not a very big traumatic event, you need to be screened sooner. Like we talked about before, decrease in our bone mineral density, it's happening at a younger age. Osteoporosis osteoporosis, it is commonly seen at our elders greater than 65 years of age, but we also have the osteopenia stage, which is not the severe detrimental decreased density in our bone, but you still have people out there, and there's studies that are out there that show patients that have osteopenia also have an increased risk of these fragility fractures. Now, the fracture to the ankle, the fracture to the wrist, or the fracture even to the shoulder, it's fine. You can live with that. Yes, you'll have some pain, some rehabbing is great. The ones that we are concerned about that are life-changing is the back and the hip. Studies have shown patients that have had a hip fracture, 25 to 30% of them, the mortality rate is within a year, they die. And then a higher percent of those, they start to not realize that we're not back to our 100% of our lifestyle. You become dependent, whether it's with a family member, a loved one, or some of them go to nursing home care facilities. So 65 years of age and greater, yes. But if there is any concern, look, I had a weird fracture, I have a family history or other medical problems, because keep in mind, like we've talked about hormones, it has a huge component in the health of our bones. There are other medical issues that can cause secondary osteoporosis, that can cause secondary issues with the bone mineral density. It could be a problem with your liver, it could be a problem with your kidney, thyroid hormones, parathyroid hormones. So it's a conversation you need to have with your physician to make sure, do I need to be screened sooner? Because I have a lot of patients that we are screening at a much younger age, and we are finding osteoporosis in them.
Wow, I did not know that. I was expecting, look, in your 60s, and that's it. Sorry. No, that's why we need to know. But we also want to answer your questions. So whoever has a question, okay.
Can you talk about women and testosterone and its importance to women?
So I'm going to take this one. I'm glad you brought it up. So as we were talking about women, we have estrogen, progesterone, testosterone. And actually, testosterone is the last hormone to, kind of dwindle away as we go into menopause. We need testosterone, and we need it just as much as we need estrogen and progesterone in our bodies. It helps with bone, it helps with muscle, it helps with cognition, and the big one, libido, okay? There are a lot of taboos out there. Number one is a taboo of menopause and aging and, oh, I'm not there. I don't want to be old. No, we're past that, so we're moving on. The next taboo is libido. And testosterone plays a big role in that and sexual well-being and function. And we need to address all of this. So I prescribe testosterone readily to all of my patients. It's part of my armamentarium of what I give them. So you get a little bit of an estrogen patch, you get some progesterone, and you get testosterone. There are different modalities of giving testosterone. There's a testosterone gel, there's a testosterone cream, and there are the pellets, and there's subcutaneous. As we all know, no formulation is FDA approved for use in women. We're working on that angle, but we'll get there. In the meantime, we are using it in female doses, okay? So I highly believe in it. Do I give pellets to everybody? No, I don't think it should be a first-line therapy for patients, because if they don't like it, we cannot take it out. But if you don't like the testosterone topical, then you just stop using it. So there, again, it's personalized, it's individualized care, but yes, it is a definite yes in my book.
What tests should be done so that a management plan can be followed?
So there are, the only real tests that we have that will tell you where you are is if you're in menopause, we can check your follicle stimulating hormone level, as well as your estrogen and progesterone and testosterone levels. With that said, in perimenopause, I still will check those levels. Number one, my patients want data. They're not just going to take my word for it, and I use it as a baseline. So I will run all labs on them. In addition to hormonal labs, we have to check iron levels. In addition to that, we have to check thyroid panel, because all of these disorders or issues can mimic one another in terms of the symptoms. So you don't want to just kind of box everyone in. Oh, it's perimenopause. Oh, it's menopause. Let's do this. But they could be having an underlying iron deficiency or a thyroid problem that you're not addressing. So we need, that's what I mean by looking at the whole woman, is you have to look at every part and then give them the right treatment plan. So in terms of labs, I do a whole panel on all of the hormone, thyroid, iron.
It's important to know there's not a normal lab per se, right? The range for normal is a huge range, and some women may be normal on the low side and completely asymptomatic, and some women may be the high part of normal but is struggling with symptoms of perimenopause. So it goes back to that idea of what is it that we're trying to treat, and it's important to know where you start, to have a baseline, see how you're responding to the treatment. But really, this is symptom-based treatment. So again, you could be completely asymptomatic and be low normal. You could be symptomatic and be quote unquote high normal. But if you're symptomatic, you don't really care that you're high normal in your estrogen. And so it's good to have these baselines, and it's good to follow them to give you some numeric to understand how these treatments are impacting your hormone levels. But there's a wide breadth of quote unquote normal. And so it's really, again, important to understand what's bothering me and what's the strategy we're going to use, be it hormone, non-hormonal treatments, to help address those issues. I think, again, it depends on what we're doing. So if you're asymptomatic, that's fine. If you're symptomatic and you're starting a treatment, then probably follow up, and again, I don't do hormone, but 8 weeks or 3 months. Let's see how you're responding to this, both symptom-wise. Hey, I feel great. All right, well, we really overshot here. Let's see if we can titrate down and still have you feeling good, but keep the levels a little bit closer to normal. Or, hey, I'm still not feeling well. You went up and we'll titrate up. So again, I think the important thing is, what are we trying to achieve in symptom management or health prevention, and how best to do that? And everyone's a little bit different. But it starts with you recognizing, all right, I don't feel right with this, and then being able to relay that to a provider that's going to listen to you, and then develop a plan together. And kind of alluded to this earlier, it's not just medication, right? It's exercise is important. It's diet. Listen, we all like to have a drink once in a while. There's no data that any kind of alcohol, no matter how little amount, red wine is good for you. But, okay, a glass of wine or a bourbon, that's okay. But there's certain things that we need to look at beyond just a pill or a treatment. It has to be a holistic approach to what are you doing in your life to give yourself the best chance to feel well. Exercise, diet, and then the other things.
Sorry. So is the new age 45 for the colon cancer screening? And why aren't all the doctors on board with that? I mean, I know you can't speak for every doctor, but still, it was interesting.
It's a newer change for the colon cancer screening, the colonoscopy or Cologuard, and it used to be 50, and now they've pushed it to 45. So yes.
Listen, cancer numbers are down in the U.S., which is great. Cancer among younger patients is up. And so, yes, very important that we follow these screening guidelines. So it used to be 50, but now it's 45, right? And uterine cancer is up, particularly in African-American women who, for reasons we don't understand, do worse. And so it's very important to follow these guidelines. The great thing is we have Google. So if your doctor says something you're not sure, just Google it and you'll see what the recommendations are. But the recommendations are 45. And again, cancer numbers are down, which is great. But cancer in younger patients, particularly younger women, is up.
I did it. I just want to say colonoscopy and endoscopy. My mom had colon rectum cancer. They had to remove her colon. So it's something that I'm constantly, I asked my doctor if I could do it very often. And it started at 39 or 40. And it makes me feel that I'm, in charge early on. So it's something that I like to address. I did one last year. I did it again. I found on my endoscopy, different things. I had a hiatal hernia. I had to address that. So you end up finding other things that, it's so good to prevent.
So how do I navigate if I'm perimenopausal or if I'm postpartum? Does it push the timeline a little further, or?
We're seeing a lot more of this. Sorry, but this is very common because women are having children later. And then that does kind of go from postpartum straight into perimenopause. So you're not wrong in what you're feeling. And again, the hormones can be fluctuating. And that's the hallmark of perimenopause, zone of chaos, right? One day it's up, one day it's low. So we don't really rely on it, but we rely on your symptoms. And so hence I would, get that addressed.
And then one more question that's not related. I am in fitness and I'm seeing the wave in Pilates. I'm seeing a lot of hot Pilates. What are your take on hot workouts? Do we like those? What do we think? Do
You're
we care?
asking the wrong person.
Okay.
Because that's all I do.
Yeah, okay, good. I just making sure.
Sorry, but I have for like the past 7 years. That's all I do is,
Okay.
hot.
I'm asking the right person then. There we go.
Right, but wrong. No. I do Tracy Anderson. If you know, you know. If you don't, it's in a hot studio and it is intense and it's intensified Pilates per se with added weights and things like that. I think for each person, to be honest with you, it is based on where they are and how they approach their fitness regimen, right? I'm all about, I see patients of all kinds, some who've never stepped in a gym, and I have others who are fitness experts. So I will meet them halfway and say, this is what you need to do. Let's get started with just walking with a vest. I'll be happy with that. And then we'll add on to it, but I'm okay with the hot workouts.
Before we move to more questions, I want to address the issue of vests.
So just to add on, and I will definitely talk about the vest, but just to add on with what she said, the key point is you want to acclimate to it. So for instance, our football players, our NFL players, that's the Dolphins, I work with them, that's a huge component in their training in acclimating to the heat. So you don't want to get to in an exercise regimen, especially when it comes to heat, just from doing nothing to all of a sudden you're in the heat, you're really working yourself out with high weights. You want to acclimate yourself, gradually get yourself into it, especially if there's any concerns of cardiovascular issues. Make sure that you talk to your doctor first before you get into any of those extreme exercises. While they are amazing and I love them, make sure you do it in a very progressive regimen and not all of a sudden. When it comes to the weighted vests, there are studies out there that show that there is improvement in terms of increasing bone mineral density, but it's showing it more for it's strengthening our gait, it's strengthening our posture. And so that is a good aspect with the weighted vests. But you don't want to ignore other weight strength training exercising. So walking is good, that pounding that you're doing, that is excellent, but incorporating other strength training exercises. Keep in mind when you're doing one movement that is repetitive, it is good, but sometimes if we overdo it, it can lead to repetitive injuries. And you're isolating these muscle groups in a certain modality of that movement. So you want to change up the exercises, the strength training exercises that you're doing. But a weighted vest is a good option to start with.
What are your thoughts on cold plunge therapy for women?
So I think when it comes to the cold plunges, it's again acclimating to it. You don't want to go all of a sudden from not doing it to throwing yourself in an ice bath where you can, cause a reaction where the body almost died. Yeah. So it's got to be a slow progression. They did say like long cold plunges might increase your cortisol levels, but I think the study's just not quite there yet. Again, if you do it in slow you acclimate yourself to it. It doesn't have to be immediately an ice bath. It can be just a quick cold shower. Keep in mind when it comes to studies, you have to isolate any confounding variables that might tell you, okay, this is the reason why it's bad for these people that are in the studies, right? It could be a correlation, but not exactly a causation that, yes, this is bad. So while we have studies out there, we have to take it with a grain of salt. Could it be bad? Maybe it isn't. Maybe there's something else that's going on that's showing overall it's bad in the long-term period of time. So it's hard for me to comment too much on that.
I hear Dr. Stacy Sims saying that she created a mess on social media by doing that, saying that it was bad for women, and she regretted because you have to look like deeper into.
Remember, with everything, the pendulum swings both ways. Go back to our longevity components, and that is why the cold plunge came into play. It's good on a cellular level. But then this new study came out that says, no, it's too much cortisol and it's bad for you. So it goes both ways. So I think it's going to land somewhere in the middle. And I know a lot of fitness people who have both. So you have the sauna and you have the cold plunge. So you do this and then you go into that. So there's a whole regimen to that. So I wouldn't just mark it off. I think if it's part of your regimen of what you do for your wellness, I'm okay with that. And I would continue. I'm personally putting a cold plunge in my backyard next to my hot sauna. So Again, you guys caught the wrong right person today.
I want to quickly bring PCOS into the chat. And we know that a lot of women go undiagnosed or are misdiagnosed with PCOS. And so how does PCOS factor into menopause, perimenopause, menopause, and vice versa?
Yeah, that's a loaded question there, Nikki. Thank you. You're welcome. So remember, we're talking hormonal shifts and how your body reacts to stress, cortisol, inflammation, all of the above. And so PCOS is just a part of the spectrum of hormonal shifts. So women with PCOS, do they outgrow it? No, they learn to manage it. Their body kind of shifts, and based on their wellness, what they eat and their nutrition and supplementation, it gets better or managed, and then later they go into the perimenopause range. So do we ever really outgrow one to get into the other? Not really. It's just you kind of manage it and you live with it. And we used to just be easy, take a birth control pill and some metformin, and that's the solution. We've moved away from that. We, again, not everyone, most, we're moving away from that because we're learning, hey, this is a shift in the hormones. Let's, bring down the inflammation. There are PCOS nutritionists now who will build a whole meal plan based on whole foods, and that will actually reverse a woman's hormone imbalance. I've seen it with my own two eyes. They get pregnant, because infertility is their biggest issue. So there are things to be done, but it has to be done in that manner.
And to follow up with that, that same method, right? Like if you have a hormone nutritionist, is that then applicable to
perimenopause? 100%. So remember, women, they can go through perimenopause starting at 39. You have 10 years. Am I saying they should be on hormones at 39? Absolutely not. Especially if they're having some symptoms, but not all, where it's not snowball affecting their quality of life. Then we will work on the pillars of health. We will dial in their nutrition. I will dial in their workout regimen, whatever that be, then add in a few key supplements. And then we wait and watch. And then they thrive for 4, 5, 6 more years until they're ready for the next stage.
Well, I have a question. I'm the youngest of 6, and my 2 older sisters, one who's 10 years older than me and the other one's 25 years older than me, and my mom, they've all had hysterectomies because our grandma had ovarian cancer. So in my mind, I'm down that road as well. And in my mind, since I never talked to my mom about her menopause, I thought I was never going to go through it because I was like, I'm going to have a hysterectomy. I'm never going to go through it. So kind of how she asked about PCOS and menopause. What about that aspect? I think somebody touched a little bit on like removing organs, but how does that factor in? And when should I guess already, but should start talking to my doctor about like, am I a candidate for a hysterectomy? I asked her if I could have one in my C-section and she was like, absolutely not. But.
So hysterectomy means different things to different people, right? So we have the uterus. So hysterectomy is removal of the uterus. It has nothing to do with the ovaries or hormones, right? But oftentimes we think of a total hysterectomy to include the ovaries, which is what produce the estrogen. If you have a familial history of ovarian cancer, then you should hopefully have undergone genetic testing to see if you carry a genetic mutation that puts you at increased risk. And if you do, that's a whole separate conversation as far as preventive medicine. Ovarian cancer, thankfully, is really uncommon. Your risk of developing ovarian cancer, if you don't have a family history, genetic risk is 1.7% in your lifetime, which is really, really low. The challenge is that there's no screening for ovarian cancer, right? Pap smears don't prevent ovarian cancer. Pap smears prevent cervical cancer. And despite our best efforts and our hopes, ultrasounds and the famous blood test, none of those things can catch ovarian cancer early when it's curable. So the challenge becomes, yes, Abuelita had an ovarian cancer. I don't carry a gene. What does that mean for me? Well, it means you're at slightly increased risk, right? Probably 3 to 5%, depends on the rest of your family history, which is not a lot. But if you watch the news, they tell you, well, you're at 3 times the risk of the general population. Well, that sounds like a lot. And so, certainly speak with your physician as far as what would be the benefit of a prophylactic surgery, which would mean to remove healthy organs before they have the opportunity to develop an ovarian cancer. And that'll help prevent ovarian cancer, but then that's going to bring in menopause, right? And so in patients like this who are young and have a family history and they want to be proactive, I do talk to them about, let's loop in your GYN and let's discuss, what are your attitude towards hormone replacement therapy after this, right? And what would be the benefits? And probably when we do that, we start it kind of shortly after surgery, so you don't go into a drastic surgical menopause, right? Because you're going into the operating room with estrogen, 20 minutes later, you don't have any estrogen. And so usually we'll start a program in collaboration with their gynecologist, and they'll usually start the patch a couple days after surgery once they're up and ambulating, and we've decreased the risk of blood clots. But it's an important discussion to understand what is your risk, what you can do to mitigate that risk, and it's up to you if that 3 to 5% seems like a lot, or if that 3 to 5%, John, doesn't sound that high. But certainly, yes, you want to be proactive, understand there's no screening for ovarian cancer, and understand that most women who develop ovarian cancer do not have a family history, right? And then, what's the risk to you? What's the benefit to you? And if you're going to pursue that, then do you want to have a plan for hormone replacement therapy afterwards or not?
My name is Iliad. I'm 45 and proud. And I think at my stage and at my stage, I think I wake up in the morning, I'm like, is today the day? So with that mindset, and I know it's coming, and I'm also very similar. I have nothing to reference as far as my mom had rectum cancer, so she never experienced menopause. So the conversation I'm having with her now, I'm like, why don't I know how you felt? Why aren't you crying? Why? And she's like, I skipped that. So I think my question to you is, can you, and somebody mentioned the word roadmap, can you give us a very general, I know it's very specific to person, but is there a general roadmap that you can recommend that is very 360, that includes a little bit of nutrition, maybe a supplement that we should be including, magnesiums of the world, a food, a fitness regimen, something that could be maybe taken on for someone that's not following anything?
That's a great question and a great place for you to start. Somebody who's 45, you're not really symptomatic, but you just want to optimize everything of what you can do. That way, going forward, you're going to feel better and not have so many ups and downs on your journey. So basically, the diet modification, I love the Mediterranean diet. It's very common. And if you actually go on Instagram, they have recipes every day that are easy to make, and it's farm to table, basically. It's, clean, low preservative. There's no preservatives in what you eat. So that is the diet component of it. I don't believe in taking anything out. Low carb, high, I don't do any of that. I don't think that's good for women, especially in midlife. You should have a little bit of everything. Okay. So that should be part of your diet. Alcohol, yes, I like my drink every now and then. I know I'm going to be the party, fun sucker. I get it. But it is the one drug we know that will lead to cancer. So the question is no alcohol, okay? Or a little bit, I don't know. Supposedly it's 0, okay? So we'll leave it at 0. Supplementation. 4 or 5 key supplements, guys. I see people, they bring in bags of supplements, bags upon bags. And it's really your vitamin D3, K, and your omegas. That's one of them. That's one little triad that I use. And then you said magnesium. Yeah, there's 7 different kinds. And I've had women come in and I take magnesium, but I'm in the bathroom all day long because you probably took mag citrate. Let's not do that. Yeah, we don't need that. That's for something else. There's a magnesium glycinate that I recommend to my patients for sleep at night. And then for the daytime, if they need some energy or brain fog, magnesium L-threonate. That's called Neuromag. Those are the 2 magnesiums. A little calcium never hurt anyone, okay? Because we're not usually getting enough in our daily diet. So again, if you know your macros, if you know what you're eating, you will know what am I getting enough of and what am I not? So that's the whole diet side of it. The strength training, the exercise regimen, right? It is cardio plus weight resistance training, whatever you want to call it, okay? 2-3 days a week. You want to implement those heavy weights in the gym. You want to be doing that, but you want to be doing it with an expert who knows the midlife woman. You do not want to go to Equinox with a 20-year-old trying to tell you what to do. You're going to walk out of there injured, and that isn't the point. The point is to improve what you're doing. Again, these are your roadmaps. This is what I give all of my patients when they come in for a consultation. We do labs, we do everything. I do mammogram, bone density. I even do transvaginal ultrasounds, a lot of them, because then I send them to you. So I get all that. That's all part of my routine on new patient to me. And then we work together to optimize them going forward.
Amazing. Well, now we have the roadmap. Incredible. We can't take any more questions, but the doctors.
We'll be here. We're going to be walking around.
And stick around so that way you can go directly to them. Thank you so much, Dr. Senemar, Dr. Diaz, Dr. Rohaidy, Dr. Kiriakou, Marta Graf. Thank you so much. And thank you, because all the questions were so amazing and so needed. And thank you to Baptist Health for bringing us together.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Baptist Health Talk is brought to you by Baptist Health, the warmer side of care.